Occupational English test has 3 parts, and in each part you hear a number of different extracts. At the beginning of the test, you will hear a beep sound. You will have time to read the questions before you hear the extracts. You will hear each extract once only. You have to complete your answers as you listen. At the end of each test, you will be given 2 minutes to check answers. Part A. In this part of the test, you hear 2 different extracts. In each extract, a health professional is talking to his patient. For questions 1 to 24, complete the notes with the information you hear. Now, look at the notes for Extract 1. Extract 1, questions 1 to 12. You hear a doctor talking to a patient called Bryan Harris. For questions 1 to 12, complete the following notes with a word or short phrase. You now have 30 seconds to look at the notes. Hello, Doctor. Good morning.
Good morning. What's your problem?
Well, last year I had a traumatic injury to my left posterior. I got hit from a boat while I was in the water. I immediately rushed to the hospital where I had to undergo surgery. I'm still having an external fixation on the wound for healing fractures in the leg. I had undergone grafting and full-thickness skin grafting, close to defects in my posterior thigh. It is almost healed right in the gluteal fold on the left area. In several areas along the graft site and low in the leg, there is several hypergranulation tissue developed.
Is there any bleeding from the wound?
No, Doctor.
Okay, what's your age?
42, Doctor.
Do you drink or smoke?
No, Doctor.
Had any other illnesses in the past?
Nothing other than Clostridium difficile in the recent past.
Are you taking any medication?
I'm taking Cipro and Flagyl.
Are you allergic to any medicine?
No, Doctor.
Any illness history of family members?
My maternal grandmother had pancreatic cancer. My father had prostate cancer, and he has heart disease and diabetes.
Well, your physical examination results are perfectly okay. Cardiology reports are regular. There is no S3, S4 or gallop. There is no murmur. Abdomen is soft. It is non-tender. There is no mass or organomegaly. Your right lower extremity is unremarkable. Peripheral pulse is good. Your left lower extremity is significant for the split-thickness skin graft closure of a large defect in the posterior thigh, which is nearly healed. Hypergranulation tissue both on your gluteal folds on the left side. There is one small area right essentially within the graft site, and there is one small area down lower on the calf area. There's an external fixation that comes out laterally on your left thigh. The pin sites look clean. There are several multiple areas of hypergranulation tissue on the left posterior leg associated with a sense of trauma to your right posterior leg. I would recommend series of treatment with chemical cauterization of these areas till these are closed.
Extract 2. Questions 13 to 24.
It up onto the computer later on. Okay. So just in your own words, tell me what's brought you in today.
Well, I've been getting some diarrhoea really, yeah, for the last sort of, 2-3 weeks.
Okay, so before 2 or 3 weeks, no problems really?
So before that, no. I mean, I've just been going normally, which is once every couple of days or something. Yeah, no problems normally.
Okay. So just tell me a little bit more about the diarrhea, what it's like and things like that.
So like what my poo looks like, sort of thing. Okay, so it's quite it's runnier, sort of looser than normal. I don't think there's any change in like colour or anything. And I probably, but I'm just going a lot more often.
Yeah. Can I just check? Do you have any blood in it at all?
Oh, gosh, yes. I'm surprised I haven't said that already. It's worrying me. That I've had for a couple of days.
And is it difficult to flush away at all?
No, it's not difficult to flush away.
Yeah, and do you ever see any food that's not digested properly in it?
No, that wouldn't be something. No. No.
So you said diarrhea, but how many times a day does it actually happen?
Well, I would say somewhere between. Well, at the moment, probably somewhere like yesterday was probably about 8 times.
8 times, dear.
I mean, I don't think it's been like that every day for the last 3 weeks, but
up to 8 times a day.
Up to 8 times, yeah.
Do you have to get up at night to go to the toilet?
Yes, yeah,
oh dear.
yeah, and I've never had to do that before.
And you're losing sleep over it?
Oh yeah.
And do you have any tummy pain at all?
Yes, it's quite sort of crampy, mainly just before I go to the toilet, but it can be at other times.
But then does that pain go away once you've been to the toilet?
Yeah, a little bit. Yeah, I would say so. A little bit.
And does anything make the pain worse at all?
Just eating. Not that I can really think of.
And you pointed to your tummy. Exactly where is it?
It is just sort of around the middle, really.
Yeah. And how do you describe that pain?
It's sort of crampy.
Crampy is what you said, isn't it? Yeah. And how bad is it? If 10 was excruciating and 1 was very little pain, then where would you put it?
It's not. I've had worse. So probably about 4.
Yeah. So it's not agonising, but it certainly is there.
Yeah.
Okay. And you've told me about when it comes on and what makes it a little bit better and worse as well, which is good. So I'm just going to ask the rest of the questions just about the whole gut itself. Do you have any difficulty chewing your food at all?
Oh no.
No mouth ulcers or anything like that?
No.
Any difficulty swallowing your food at all? Do you ever get indigestion?
No.
Not really.
Well, sometimes, maybe on a weekend. Sometimes.
Okay, but not usually.
No, not usually.
So this was only about 3 weeks ago that you've had the problem.
Yes.
Okay. And prior to that, what was your bowel habit like?
I don't go that often, really. Sort of maybe once a day, once every 2 days.
Once a day, once every 2 days, but certainly no diarrhea.
Oh no.
A normal form still.
No, it's quite harder. If anything.
But no blood, not black at all.
No.
Okay, that's great. Thank you very much for that. On to your past medical history. Any operations in the past at all?
Yeah, I did when I was sort of in my teens. Probably, I think I was about 15. I had my appendix removed.
In your teens, okay, but nothing since then. No big operations since then.
No.
Okay. You said that you take a little bit of paracetamol for your headaches.
Yes. Yeah.
Okay. And are you doing any of the medicines at all?
Just the pill. Yeah. No, nothing else.
Nothing else at all. Okay. And nothing else over the counter?
No, just paracetamol for my headache.
Any recreational drugs at all?
No.
Okay. And are you allergic to anything?
Oh, yes. I'm allergic to amoxicillin. So is that penicillin?
Yeah.
So we're allergic to penicillin.
Okay. What happens when you have penicillin?
Oh, that's what I get. That's when talk about a rash. I get a rash.
Oh, I see. So that's the rash.
Well, no, but yeah.
Yeah. Okay. So rash with penicillin. So who's with you at home?
So I live with my partner, Sam.
Okay. No particular problems there at all?
No.
Okay.
It's been about 3 years.
Is there any family history of note?
No, not I'm aware of anyway.
No gut conditions in the family?
My aunt maybe. My aunt had something to do with her tummy, but I don't know what it was really.
Okay.
It wasn't cancer.
So just moving towards the end, I just wanted to explore your ideas, concerns and expectations really. So what do you think is going on with this problem?
Well, I think it could be an infection.
An infection, yeah. And you told me about one of your concerns about passing it on to people at work, and especially the children, I guess. But any other concerns?
Well, they pass on to me.
Yes.
My friend's sister has got bowel cancer, and she's only 30.
Oh dear.
And so it's just the bleeding, really, more than anything, that's worried me. So I wondered about that, really.
I mean, I'm glad you told me that. We'll try and reassure you, and let's see what turns out in your case. What do you think we need to do today to help you?
Well, I wondered if I might need some tests. I mean, I'm really hoping, because I did have a little look on the internet, and I'm really hoping it's not going to be one of the cameras. I think it's colonoscopy or something like that. I'm hoping I don't have to have that.
Sure. Okay, I think I've got everything there. Is there anything else that you want to tell me? Actually, I've just remembered, I forgot to ask you about travel. Have you had any travel in the last few months or weeks even?
No, I haven't been away anywhere.
Okay,
no.
And you can't distinctly say that this is due to a particular food that you've had, and nobody else has had this problem in your family?
No.
Just wanted to check that.
Yeah.
Okay, so is there anything else that you want to tell me about this problem?
No, I did go travelling about 3 years ago to Africa.
All right, 3 years ago.
Yeah.
Okay.
I went to South Africa and up into Zimbabwe.
But were you well there, though?
Yeah, I was well. Yeah.
Okay.
Yeah.
Okay. And do you have any questions for me?
No. How likely is it that I'm going to have a camera?
Well, I think initially we'll probably run some blood tests and do the stool sample, and make sure there's no infection. Then I probably need to get a gut specialist to have a look at you if it hasn't got better in a matter of weeks.
That is the end of Part A. Now look at Part B. In this part of the test, you will hear 6 different extracts. In each extract, you'll hear people talking in a different healthcare environment. For questions 25 to 30, choose the answer A, B or C, which fits best according to what you hear. You will have time to read each question before you listen to the audio. Complete the answers as you listen to the audio. Now, look at the question 25. You hear a discussion about common types of neuropathic pain. Now, read the question.
Hello, Doctor. What are the common types of neuropathic pain?
Well, while there are countless types of neuropathic pain, some of the prominent types include carpal tunnel syndrome. Is caused by nerve compression in the wrists and causes pain in the wrist, thumb and fingers. Central pain syndrome can occur after nervous system damage, such as a stroke. Degenerative disc disease, one may feel neuropathic back pain if it causes damage to the nerves entering or exiting the spine. Diabetic neuropathy causes stabbing pain in the hands and feet of some diabetic patients. Phantom limb pain can occur in some patients after a limb is amputated. Postherpetic neuralgia is brought on by an outbreak of shingles and persists after the condition has cleared. Pudendal neuralgia is a type of pelvic pain caused by compression of the pudendal nerve. Sciatica is caused by compression or irritation of the sciatic nerve and often results in shooting pain that radiates down the back of the leg. Trigeminal neuralgia is characterized by shooting neck and facial pain. Question 26. You hear a discussion bronchodilators used to treat chronic obstructive pulmonary disease. Now read the question.
Hello, Doctor. What are the different types of bronchodilators used to treat chronic obstructive pulmonary disease?
Patients with chronic obstructive pulmonary disease are often prescribed a bronchodilator, a type of medication for relaxing the air passages to help breathe better. Typically, the medications are inhaled through the mouth using a metered dose inhaler, but also come in liquid, pill, injectable or suppository formulations. The 3 classes of bronchodilators commonly used to treat chronic obstructive pulmonary disease are beta-adrenergic, beta-agonists, anticholinergics, methylxanthines. Beta-adrenergic agonists are a type of medication that binds to specific receptors in the lung called beta-adrenoceptors. By doing so, they block the trigger to bronchial spasms and allow airway passages to open. Beta-agonists can either be short-acting or long-acting, which are delivered either orally or through a metered dose inhaler. Generally, the inhaled method is preferred as it alleviates symptoms faster. Anticholinergic blocks the neurotransmitter acetylcholine in the central and the peripheral nervous system to its receptor in nerve cells and inhibit parasympathetic nerve impulses. Methylxanthines affect not only the airways but stimulate heart rate, force of contraction, and cardiac arrhythmias at high concentrations. Question 27. You hear a discussion about pancreatic neuroendocrine tumors. Now read the question.
Doctor, what are the various types of pancreatic neuroendocrine tumors?
There are different kinds of functional pancreatic neuroendocrine tumors. Gastrinoma usually forms in the head of the pancreas and sometimes forms in the small intestine. Most gastrinomas are malignant. Insulinoma forms in the head, body or tail of the pancreas. Insulinomas are usually benign. Glucogenoma forms in the tail of the pancreas. Most glucogenomas are malignant. VIPomas, which make vasoactive intestinal peptide. Somatostatinomas, which make somatostatin. Question 28. You hear a discussion about melasma and different types of melasma. Now read the question.
Hello, Doctor. What is melasma and what are the types of melasma?
Well, melasma is a common patchy brown, tan or blue-grey facial skin discoloration, normally seen in women during their reproductive period. It typically appears on the upper lips, upper cheeks, forehead and chin of women of 20 to 50 years of age. There are 4 types of pigmentation patterns are diagnosed in melasma: epidermal, dermal, mixed, and an unnamed type found in dark-complexioned individuals. The epidermal type is characterized by the presence of excess melanin in the superficial layers of skin. Dermal melasma is defined by the presence of melanophages throughout the dermis. The mixed type includes both the dermal and epidermal type. In the 4th type, excess melanocytes are present in the skin of dark-skinned individuals. Question 29. You hear a discussion about possible causes of arthritis. Now read the question.
Hello, Doctor. Can you tell me what are the possible causes of arthritis?
Osteoarthritis is associated with cartilage damage. Genetic conditions are thought to play a role in osteoarthritis. Age alone is no longer seen as the cause of osteoarthritis. Rheumatoid arthritis is an autoimmune disease that develops as the immune system malfunctions and attacks the body's own tissues. Gout develops when excessive uric acid accumulates in the body and crystals are deposited in the joints. Reactive arthritis causes joints to become inflamed as a result of an infection that triggers the immune system. Usually, this condition resolves. Question 30. You hear a monologue of a physician on granulomas. Now, read the question. Granulomas are tissue nodules of immune cells that occur in diseases such as sarcoidosis and tuberculosis that can damage many organs. It is the chronic activation of the metabolic sensor mammalian target of rapamycin that is responsible for the granuloma's formation. In sarcoidosis, this mechanism leads to a course that is chronic and difficult to treat. Since mammalian target of rapamycin inhibitors belong to a group of drugs already licensed for clinical use, these findings offer new and quickly testable treatment options. This is the end of Part B. Now, look at Part C.
Part C, questions 31 to 42. In this part of the test, you'll hear two different extracts. In each extract, you'll hear health professionals talking about aspects of their work. For questions 31 to 42, choose the answer A, B, or C, which fits best according to what you hear. Now, look at extract 1, questions 31 to 36. You now have 90 seconds to read questions 31 to 36.
Now, answer question 1. The word migraine is derived from the Greek word meaning pain in half the head, as migraine often produces a unilateral or one-sided headache. It is a common and distressing disorder, and although they are not likely to take life, migraines can destroy the quality of life. Studies have shown the incidence of migraine to be in the range of 9 to 10%, and it affects 17% of the female population and 6% of the male population. So, about 2 million Australians can expect to suffer from migraine, and that translates to 1.5 million women and about 500,000 men. It is thought that more women suffer migraine than men due to hormonal factors. There are several types of migraine, the two main types being classical migraine and common migraine. Classical migraines are preceded by an aura, the duration of which varies between 15 minutes up to almost an hour. The headache usually lasts 6 to 8 hours, although they can last up to 72 hours. Common migraines are not preceded by an aura, and the headache lasts between 4 and 72 hours and can be pulsating and unilateral. An upset stomach and vomiting are common symptoms. Migraines can be divided into a number of distinct phases. The first phase includes the early warning symptoms. A significant number of migraine sufferers experience warning symptoms for up to 24 hours before the attacks start, but may not recognize these signs unless they know what to look for. The common symptoms include changes in mood, And these moods can vary from elation, such as feeling on top of the world and full of energy, to opposite moods, such as feeling depressed and irritable. There are several abdominal symptoms common to migraine, including nausea, changes in appetite, such as intense hunger or sugar craving, constipation, and diarrhea. Neurological changes may also occur prior to the migraine, including drowsiness, incessant yawning, symptoms of dysphagia, such as difficulty in finding the right words, a reaction to excessive brightness or sound, and difficulty in eye focus. There may also be changes in behaviour, such as hyperactivity, clumsiness, or lethargy. And many sufferers report muscular symptoms, such as general aches and pains. The second phase is the aura. The aura accompanies migraine attacks in about 20 to 30% of migraine sufferers. The most common aura symptoms are visual disturbances such as bright, zigzag lines and flashing lights. As well as that, there may be difficulty in focusing or blind spots. The aura commonly affects only one eye, but it can disturb the visual field of both eyes. It usually lasts between 5 and 60 minutes, then the vision normally returns to normal. Less commonly, aura affects sensation or speech. The third phase is the headache. The headache phase can last for up to 3 days. It is often throbbing and on one side of the head, but it can affect both, and it is made worse by any kind of movement. The most common accompanying symptoms in this phase are sensitivity to light, sound, and smell. Eating can help reduce symptoms, especially starchy foods such as breads and pastas. The symptoms can be more distressing than the headache itself. The final recovery stage may last for about 24 hours, and feelings range from complete lethargy to feelings of high energy and even euphoria. Sleep often is beneficial for adults, while effective medication can improve attacks for chronic sufferers. Children seem to feel much better after vomiting, and for a few, nothing works except the headache burning itself out. The dietary triggers include alcohol, especially red wine, certain types of food, notably aged cheese or chocolate, withdrawal from caffeine or caffeinated drinks such as coffee and tea, the food additive monosodium glutamate, dehydration, and inadequate meals. Environmental triggers include bright sunlight, flickering lights, strong smells, for example, perfume, gasoline, chemicals, smoke-filled rooms, and certain food odours. Another environmental trigger is high altitudes or flying. Weather changes can be a trigger factor, as can loud noises or overuse or incorrect use of computers.
Now, turn over and look at Extract 2, questions 37 to 42. You now have 90 seconds to read questions 37 to 42.
here with Dr. Jeffrey McLean, who's an expert in neuromuscular disease. Tell us a little bit about your background. How did you become a neuromuscular disease expert?
Well, I started out with my general neurology training, which I did at Wilford Hall Medical Center. And from there, I did a fellowship in neuromuscular medicine before returning to where I am now.
And what's your typical day like? What kinds of patients do you see?
I see a fairly broad mix of patients, but when I'm doing specifically neuromuscular medicine, I do a lot of procedures, electromyography, which is a procedure that we use to help diagnose neuromuscular diseases. The type of patients we see range from patients with neuropathies to patients with muscle diseases that we call myopathies, to patients with disorders of the connection between the nerves and the muscles, neuromuscular junction disorders such as myasthenia gravis, to problems with the motor neurons such as ALS or amyotrophic lateral sclerosis.
So a variety of very common diseases and some that are more rare and have very serious prognoses.
Exactly, that's right.
And what is the most exciting new development in your field? Which of those conditions have something new to offer patients who are listening?
I think perhaps the most exciting field where we've seen a lot of attention recently has been ALS, especially with the Ice Bucket Challenge recently that garnered so much public attention, so much public excitement. That excitement has transferred into more attention, more funding for more research, things that are looking at improving our understanding of the genetics that play into ALS, where there's a lot of work being done trying to find biomarkers, so things that can be tested easily to more readily diagnose ALS and understand how it progresses in a particular patient. All these things ultimately help us find and research possible treatments that in the end are hopefully will lead us to things that will really benefit patients.
And up until now, there really has not been a great deal to offer an ALS patient. What do you do today?
Right now, what we're focused on is improving the quality of life while people are dealing with this disease. And that's an important thing for both patients and physicians to understand, that while we don't have a cure, there are many things that can be done to significantly improve the quality of life for our patients. So things like help with communication, because many of the patients lose the ability to control their voice and control their speaking. So we can do things to help them communicate as that occurs. Things like assistance with nutrition, because they have difficulty swallowing and eating. So helping them with that. One of the big and often under-recognized problems with ALS are mood problems that go along with it. Obviously, it's a devastating diagnosis, and the social support is very important, that we offer that to our patients to make sure that their quality of life is as high as possible while dealing with this.
And on the other end of the spectrum, we have neuropathies for which we can offer a whole variety of treatments. Is there anything new or exciting for the patient with diabetes or someone else with neuropathy to consider?
Well, again, there's a lot of new research going on. There's a lot of exciting work in terms of trying to find ways to treat the often painful diabetic neuropathies. There are already some drugs currently available that many patients will be familiar with, and as time goes forward, we hope to increase the number of drugs that are available to make them more effective with fewer side effects. So hopefully that will be very soon on the horizon.
That is the end of Part C.